Hello, everyone. I want to share our experience with ultra-low profile new stent graft, Minos. Nowadays, majority of infrarenal abdominal aortic aneurysms are performed with endovascular methods. Baseline aortic arterial anatomy characteristics are fundamental criteria for appropriate patient selections and key determinants of term of success. Small access is a significant factor for EVAR contraindication in about 20% of the patients. Access vessel less than 6 millimeters and tortuous anatomy enable most of the conventional EVAR system to be successfully introduced. Minos is three-piece polyester cover stent graft with ultra-low delivery system. The main body is 14 or 16 French sheets according to the graft size. And the limbs are 12 French sheets. The ipsilateral length of the main body stent graft is 100 millimeters and lateral length is 80 millimeters. And the diameter of the ipsilateral and contralateral distal ends of the fixed is 12 millimeters. The diameter of the proximal ends of the limbs are also fixed at 14 millimeters. Minos is applicable to abdominal aortic aneurysm with proximal aneurysm neck length more than 50 millimeters and the angulation up to 60 degrees. The system is designed for aorta with width from 17 to 31 and iliacs from 8 to 22 millimeters. The system allows for in situ length adjustment up to the 3 centimeters through adjustment the overlap between modules components. It reduces the risk of unintentional coverage of hypogastric overstenting and minimize use of iliac extension. We want to share the case with the 68 years old male admitted with AAA disease. His sac diameter was 61. He has performed in past CABG operation. He suffered from diabetics and hypertension. Also, he has undergone laparotomy many years ago because of the cancer disease. The system allows to perform procedures percutaneously. The system is very flexible and allows for easy insertion even with narrow and difficult iliac arteries. Despite its low profile, it's clearly visible on monitors. Once the systems are in place, the attention should be paid to the proper alignment of the limbs, and we have to be very carefully to adjust the system to the aorta. Once the systems are in place, if you see the inverted 7, it means that the contralateral leg is in position behind. If a 7 is visible, it means that the contralateral leg is in front. There are also 4 markers, each in the proximal part of the stent graft and the end of the legs, which facilitate accurate stent graft positioning. The low profile also possesses a risk of the system slipping off during launching. So in my experience, the proximal marker should be positioned 1 or 2 millimeters below the inferior margin of the lower renal artery. I really believe that it's much safer to push the system instead of pushing down, which could cause the aortic damage. System opening is performed in clockwise motion. Once the 2 segments are released, I believe a control angiography must be performed. Opening the system is easy, smooth, and accurate. I always try to do it slowly and with full control of setting. At this stage, the graft can finally be precisely positioned in relation to the renal arteries. After launching contralateral leg and after coronary release, I don't open the ipsilateral leg. I leave the sheet on the cannulate the contralateral leg. Before the insertion of the contralateral leg, angiography should be performed to visualize the division of the common iliac artery. Angiography should be performed before insertion of the leg. Because it is difficult to perform this study after the insertion of the leg, the 12 French system make it impossible to perform a proper examination. When the contralateral leg is in the proper position, we release this contralateral leg. When the contralateral leg is released, I finish releasing the ipsilateral leg. We unbutton the sheets, and removal of the system is easy, and there is no danger of the olive being cut of the free flow. After we release the contralateral leg, we are coming back to the ipsilateral leg. We release the sheets, and we put the ipsilateral leg, and we connected two sheets. Once the two sheets are connected, we release the leg in a clockwise motion. It's a very important moment in the releasing, because the two sheets are connected and we have to move the two sheets simultaneously. Therefore, the sheets cannot be held. This will cause the leg to disconnect. And also the system allows to adjust the length up to the 3 centimeters. At the end, I always complete the procedure with a low pressure balloon. We see the releasing two sheets together at the ipsilateral leg. It's going very smoothly with no any problem. Now we put the low pressure balloon. We have to adjust the system to the aorta and both iliacs. The system is low profile, so we have to do this manner. And at the end, of course, we do the finally angiography to be sure that everything is going okay. The innovative ultra-low profile enables physicians to manage challenges and anatomies with EVAR, access artery with stenosis and calcification, Turch's access artery. In our experience, we have done totally 18 patients, 5 female patients and 13 male patients. Mean AAA sac diameter was 61, mean neck vessel diameter was 24, mean neck length was 17. We have achieved 100 procedural technical success. Mean device implant time was 57 minutes, mean fluoroscopy time was 23 minutes, mean total procedure time was 46 minutes. And most of the patients we discharge up to 2 days. So far, our median follow-up is 3 months. We found out 2 endoleaks type 2 with no sac enlargement. We didn't see any problem with renal function, and we didn't do any reintervention. So ladies and gentlemen, in conclusion, we can say that ultra-low profile stent grafts makes less trauma, less bleeding, less complications, less discomfort, increased applicability. It could be made percutaneously in local anesthesia, and we can discharge the patient very early. But of course, as ever, carefully follow up is mandatory. Thank you very much.